Ejaculatory problems either too fast, too slow, or not at all. Now, it has been said that emission, ejaculation at the time when you reach orgasm is the utmost thing for propagation of mankind. Without that, nothing can move. So it's so important that this process of ejaculation, which is the discharge of semen, often containing sperm from the male reproductive, is quite vital for propagation of mankind or womankind or whatever. It's usually accompanied by orgasm. If you look at the definition, there are two separate things you got to look at. One is the emission, the other one is the ejaculation. Emission is whereby the fluid from the epididymis, which includes the sperm as well, from the seminal vesicles, prostate gland, and prostatic urethra and bladder neck gets settled in the prostatic urethra. And this involves the secretion of spermatozoa and products from the other accessory glands, followed by ejaculation. And ejaculation is actually the propulsion of the seminal fluid along with the semen, along with the spermatozoa to the erythromatous. And this process will only occur when bladder neck is closed and there's associated rhythmic contractions of the pelvic floor muscles, as well as the ischiocavernosus and bulbospongiosus muscle. If you look at the anatomy, during emission, the secretions from the semen and the spermatozoa from the epididymis goes through the vas deferens, combines with the seminal vesicle, enters into the ejaculatory duct, and comes to the prostatic urethra. At the same time, the prostate will also secrete fluid, which all stays there. And at the time of ejaculation, the bladder neck closes, and there's a rhythmic contraction, which then propels the sperm out and the semen out through the penis. These things just doesn't occur without just by itself, but it's very important that there is a neural coordination of the ejaculation, which comes from the higher centers, whereby the excitatory stimulus from the efferents will go up the centers in the brain itself, and then it transmits down through two main tracks. One is the sympathetic system, which is responsible for emission, and you've got the spinothalamic tract, which is the generator for the ejaculation. So this occurs first, followed by this, whereby ejaculation takes place. And along with it, it's also important that we should know about the role of the neurotransmitters and hormones. Dopamine, which is very rich in the brain, is important in facilitating ejaculation, whereas serotonin, it inhibits the influence on ejaculation. At the time when you reach orgasm, just before orgasm, the dopamine surge is very high, and at the same time, when you reach orgasm, the prolactin actually suppresses. It comes and stops this suppression of ejaculation when it's already completed. And that's when a male, as compared to a female, when you reach orgasm, they actually go into some kind of exhaustion, and you need some form of refractory period of time before you can actually have your next orgasm, as compared to a female, where you can actually have multiple ejaculations over that same period of time. The additional players are also as stated here. The other important definition which we need to know is ILT, because lots of studies is based on looking at the intravaginal latency time. That is the duration that begins at the time of intromission, that means penile entry into the vagina, and ends at the time of ejaculation or exhaustion. Now, ejaculatory dysfunction is actually the second commonest problem apart from ED as far as male sexual dysfunction is concerned. And a lot of patients actually have this problem but do not come up front with this problem and see us. What are the conditions which can happen? It can be delayed ejaculation, can be premature ejaculation, and these two are far more the commonest type of ejaculatory problems which we deal with on a day-to-day basis. And then you have the retrograde ejaculation and NREC ejaculation. These last two will present with no semen at all, absence of semen. Delayed ejaculation is a persistent or recurrent difficulty or delay in the absence of attaining orgasm after sufficient sexual stimulation. He has had enough sexual stimulation and he's gone beyond a certain period of time, and usually most of the time they go into a period of exhaustion because of no ejaculation at all. The studies conducted by Waldinger over 500 couples in 5 countries, they found that the normal median time is 5.4 minutes, and it can range from 33 seconds to 44 minutes with a 21 to 23 minutes on average. So anything more than 25 minutes, if a man cannot reach a climax or experience distress after that, normally you meet the criteria for delayed ejaculation. I think if you can go beyond 25 minutes and still go on having sex without ejaculation, I must respect that gentleman. But probably not Abang Sador. Now, what are the causes of delayed ejaculation? It can be either be primary, which is a lifelong problem from the time they started their sexual activity, immaterial of the number of partners they've gone through, or it can be secondary or acquired cause, which could be a surgically related problem, a medical disease, or psychosexual problems. Now, all these ejaculatory problems, there's a lot of psychosexual issues involved, and in delayed ejaculation, some of the psychosexual problems which these patients can come out with is what is known as conflicted masturbation. The term is very misleading, or could be quite confusing, but what it means simply is that there is a conflict in his mind about whether masturbation is right or wrong. Lots of religious beliefs, lots of peer group pressures, lots of this thing within himself can have a conflict in his mind that masturbation is not good, not good. So this kind of conflict plays in his mind. Then you have got what is known as autosexual orientation, whereby these patients, they find that when they masturbate, they are able to achieve orgasm much better than when they have sex with their wife or their partners. They're not able to achieve orgasm with normal sex as opposed to having masturbation. So that's what you mean by autosexual orientation, and that can lead to increased masturbation or all kinds of idiosyncratic masturbations. You can also have decreased sensitivity. This usually happens over time as an acquired cause, or it could be a physical or a subject mismatch. That means with partner A, they have delayed ejaculation, with partner B, they're perfectly normal. The surgically acquired causes can be due to RPLND, which is the operation which we use mainly for retroperitoneal lymph node dissections, mainly for testicular tumors, where they have involvement of the peritoneal, in the abdominal nodes. We do this kind of surgery. If you undergo splenectomy for tumors and all forms of pelvic surgery, because you do destroy or do injure the sympathetic, the parasympathetic, and the pelvic splanchnic nerves, which are very important and vital in the process of emission and ejaculation. Some of the secondary causes for delayed ejaculation can be due to endocrine causes, can be due to thyroid problems, testosterone, elevated prolactins, and also some interplay with dopamine. The medications which are usually implicated in delayed ejaculation includes SSRI. SSRI is selective serotonergic reuptake inhibitors, which is commonly used for depression by the psychiatrists. And this basically what happens is it increases the serotonin, which then decreases the sensitivity and causes delay in ejaculation. You also have antipsychotics which antagonizes dopamine activity, which is important in influencing the process of ejaculation. You also can get elevated prolactin levels because of the antipsychotics, again, which is counter-ejaculatory. Some of them have got some inhibition of the adrenergic tone of the bladder neck. And obviously anti-androgens. If you're using anti-androgens, you do get loss of libido and poor sexual performance. Neurogenic causes can include diabetes being the most commonest, and diabetes will be mentioned everywhere. Diabetes in delayed ejaculation, diabetes in premature ejaculations, diabetes in retrograde ejaculations, diabetes in ejaculation, or in all these various problems of ejaculatory dysfunction, diabetes seems to be the common factor. Then you can get multiple sclerosis or spinal cord injury. Age-related factors, obviously as you age, you find that you can get decrease in penile sensitivity, and because of the atrophy of the dermis and the underlying stroma, you can get accumulation of chronic medical conditions as you grow old, chronic pains, renal diseases, vascular conditions, and so on and so forth. Last but not least is stress. Lots of us in this present world, we are chasing after money, paper, prestige, and therefore our lifestyle changes. We don't have much time at home, lots of work, and all these can cause stress, performance anxiety, fatigueness, and all this is important. I always tell my patients, you need a clear mind when you're having sex. If you don't have clear mind, just a little bit during the intercourse itself, you'll be thinking, oh, I've not finished this part of my work, or my boss is going to call me later, what's going to happen? Obviously, you can't perform at that point in time. So when you evaluate these patients, the following things has to be looked at. Obviously, you need to look at the religious and ethical beliefs. Age, when he first ejaculated, the pattern of ejaculations, difficulty with sex versus masturbation is the autosexual problems, lifelong versus gradual, and whether there's any relationship problems. When you're evaluating under the lab problems, you look for endocrine problems, basically testosterone, thyroids, prolactins mainly, and obviously you do the FSH and LH as well. When you're looking at the patient, you're going to rule out endocrine problems, whether they have hypothyroidism, whether they have any loss, any testicular deficiency syndromes, and whether there's any abnormal prostate problems which can predispose to ejaculatory dysfunctions. When you're going to treat this patient, very importantly is, I keep stressing on the psychosexual part of it, because a lot of these issues are mainly psychological in origin, so it's very important to educate the patients on the mechanics of sexual intercourse and orgasm, because many a times you do see sporadically that they've actually been having sex through the wrong orifice. Establish an anxiety-free environment, obviously, engagement of partner in therapy. And this is very important because sometimes a lot of males come alone with this problem. They say, my isteri saya tak berapa puas hati, dia nak cari orang lain, dia dah minta surat nak cerai. I've had one lady who actually came to me with her husband, first with problems of ED and premature ejaculation, and after a few months, she came back and saw me and said, I want a letter. I said, what letter? Letter to say that my husband is not able to perform because I want to marry another one. I've already found another partner. I want to marry this guy and I need a letter. I said, I'm sorry, I cannot give a letter without your husband's consent. If you get a court letter saying that you want me to release a letter saying that your husband is not able to, then I will release, but not on your request. So she went off, but eventually she married as well. So there's a lot of things you can do for delayed ejaculation, whereby there's a lot of homework to be done by the couple. Don't think that you only homework with regards to your children, but also when you're having sex, you must do some homework. The first is to achieve ejaculation without coitus, because the main issue is when the person is exposed having sex, they can't ejaculate. So try to achieve ejaculation without coitus first, then slowly bring the male to the brink as they're masturbating towards when they're about to reach the climax or the orgasm. Insert the penis into the vagina to provide the final stimulation. This will gain the confidence of the male and breaks the mental barrier. Masturbation, retraining to acclimatize the male to stimulation similar to partnered intercourse as well. And as they are doing this, and when they start becoming successful, then you can ask them to reduce the frequency of masturbation. Obviously, the other issue is when you have delayed ejaculation is trying to retrieve the sperm for the purpose of fertility, because some group of patients have sex, they cannot ejaculate, so they can't have children. So for the purpose of fertility, obviously you can do certain maneuvers like what Dr. Hatta has mentioned, either bilateral ejaculation or PESA or TESA. If you have an endocrine problem, you can address the endocrine problem, especially the hypogonadism, hypothyroidism, and hyperprolactinemia. SSRIs, if the patients are on SSRIs, you would want to consider changing them or switching them to something less problematic as far as ejaculation is concerned. And if they are on other types of antipsychotics, you now have newer agents that affect dopamine less and cause less hyperprolactinemia. So all these can be considered to change the approach in managing the problem of delayed ejaculation. Now, among the pharmaceutical treatment which you can employ is you can use alpha-1 adrenergic receptor agonist, which will help to increase the ejaculation. You can use antihistamines and antiserotonin, and you can use carbapenem, which is the one which is used for hyperprolactinemia. All these are pharmaceutical maneuvers which you can do to try and improve the situation. I wouldn't bore you with this. These are all some dosages, but usually most of these drugs are not readily available in this part of the world as well. That's the thing. Yohibin is already being taken off the market at this moment, and by KKM as well. So in conclusion, as far as delayed ejaculation is concerned, I haven't finished yet. It's difficult but common psychosexual causes make this condition complex to treat, and obviously pharmacological treatments are evolving at the moment. Now quickly, if I run through premature ejaculation, it is a much more common problem as compared to delayed ejaculation, and the incidence is about 20 to 30%. The ILT for clinical trials is under 2 minutes, but usually most of them present under 1 minute, within 30 seconds, less than 30 seconds, which can be quite a problem. And you can broadly classify it as a lifelong problem or a quiet problem. The risk factors will be older age group, higher BMI, when they have comorbid factors like diabetes, hypertension, loss of libido, ED, prostate problems. And obviously this is another group of patients, performance anxiety. They're so stressed that they've had once premature ejaculation. The next time they go and have sex again, they're always worried. And what happens is anxiety activates the sympathetic nervous system, reduces the threshold, and results in early emission. As far as history is concerned, you would want to look at the details of the PE, whether it is acquired or lifelong, whether relationship to partners, whether it occurs with only some attempts or all attempts, degree of stimulus resulting in PE, whether they are involved in other form of sexual activities, and so on and so forth. Now, most effective approach is actually a combination of psychological assistance and medical intervention. You can't just rely on one. The couple, The couple should have an understanding of the problem and need to work together to try and improve the situation. You obviously got the squeeze and start technique during the intercourse itself to try and delay the ejaculation. One of the commonest things which I normally use is EMLA cream, which I ask the patient to apply on the glans penis about 20 minutes before the intercourse so that it numbs the area a bit, and obviously they can delay the process of ejaculation. But obviously there's a small setback in this whereby the male partner might feel that he doesn't have that satisfaction because of the numbness. Just now I mentioned about SSRI causing delayed ejaculation. So you use this as an advantage to treat problems of premature ejaculation so that the reverse occurs. PDE5 inhibitors does have a role whereby the rigid erection forces hurry to reach the climax. But what happens is after the first intercourse, for a male to have the next intercourse within that period of time, there is a little bit of time involved. So PDE5 will actually reduce the refractory time before a second erection, and this second erection usually can last longer than the first erection as far as ejaculation is concerned. You now have on-demand SSRI, which is known as tepoxetine. It is a short-acting SSRI. Not many side effects only for mild nausea and vomiting, and you take it about an hour before the intercourse. In this country, it is marketed as Privilegy. It's taken about an hour. Quickly moving on to retrograde ejaculation. What happens is, as Dr. Hatta said, instead of finding the easy way out, instead of finding through the normal anatomical pathway, it takes the easy way out because the bladder neck is open. Due to the bladder neck being open at the time of ejaculation, the sperm gets into the bladder and then comes out through the urine. And a couple of causes which are implicated will be diabetes, multiple sclerosis, and surgical injury, especially in TURP. And ejaculation, on the contrary, is basically failure of emission. That means completely no emission into the prostatic urethra, and therefore there is no ejaculation at all. And usually it is due to some kind of somatic contraction problems of the ejaculatory structures, including the epididymis, and diabetes is one of the main culprits for this. Again, you talk about diabetes in an ejaculation as well. You also can get it in spinal cord injury patients and in other neurological diseases like multiple sclerosis and transverse myelitis. And obviously in surgeries. If you're doing RPLND or pelvic surgeries, you can cause problems to the sympathetic chain and the pelvic nerves. 5 more minutes or finish? And the other group of reasons why you can get retrograde ejaculation is the usage of alpha blockers, because alpha blockers again will keep the bladder neck open and therefore the ejaculate enters into the bladder and comes out. And the common drugs which has been implicated is silodosin and tamsulosin, which is used for BPH patients. How do you differentiate the retrograde versus anejaculation? Normally have a normal orgasm in retrograde. It is a normal, no or low volume ejaculate. Post-orgasm, when you ask the patient to empty before ejaculation and immediately after, if you have greater than 10 sperm per high power field in a centrifuge specimen, post-orgasm, it is indicative of retrograde ejaculation. In the case of lack of emission, there is no sperm in the urine at all. And how do you treat this problem? You can use alpha agonist, which tends to improve the sympathetic tone in the vas deferens, seminal vesicles, and bladder neck. And it is probably enough to overcome the disrupted sympathetic plexus, but the clue to this is that most of the patients who would benefit are the patients at baseline. They have some form of climax and rhythmic pelvic contraction with little or no flow of fluid per urethra. The treatments which has been used for retrograde ejaculation would include the pseudoephedrines, imipramine, and midodrine. For spinal cord injured patients, as Dr. Hatta showed the diagram, you can use vibratory stimulation, or you can use the process of electroejaculation. Both are for the purpose of trying to stimulate the afferent and the efferent fibers to create some form of emission and ejaculation. Last but not least is the issue of ejaculatory duct obstruction, which is usually identified by low volume, low pH, and a negative post-ejaculatory urine analysis. How do you diagnose it? You have to do a transrectal ultrasound. Essentially, the causes will be stones in the ejaculatory duct. You can get Mullerian cysts, you can get stenosis of the ejaculatory duct, and these are the commonest causes why you do get problems of EDO. And one of the ways you can actually do is when you do a truss, you find that the seminal vesicles are quite dilated. Well, it's 1.57 cm, but probably about 1.5 and above is considered acceptable. Whereby when you do an aspiration of these seminal vesicles, you get millions of sperms within, which is very indicative of EDO. We used to do Tourette those days for Mullerian duct cysts and ejaculatory duct obstructions, but there are few setbacks. You can either get improvement or you can get retrograde ejaculation because you might destroy the internal sphincters, or you can get no change at all. That means you can get an epididymal blowout, and complications associated with Tourette is quite high, in the range of 25%. So the easy way out is, again, trying to retrieve it via the method of ICSI, which is perfectly done with low mobility and local anesthesia, and it's got a very high success rate. So in conclusion, ladies and gentlemen, next to ED, the ejaculatory duct disorder is the next most commonest problem. It consists of premature ejaculation, delay, and ejaculation and retrograde, but mainly we are dealing with, most of the time, is premature ejaculation and delay ejaculation. It definitely requires a full evaluation of this issue before we can address how to treat these patients. There's obviously hope and therapies available at this very moment, especially the pharmacological treatments are evolving to resolve the distress of the ejaculatory dysfunction. Thank you.